Hi friends, today we're going to learn about adolescent femur fractures. So why do we need a separate group for these fractures? Because femur fractures are the most common cause of hospital admission in the adolescent age group, with accounting for more than 60% of the total pediatric femur fractures. They share a watershed line between the adults and the children. Because they are more stronger and built, you might need to consider more refined methods of decision making and planning the fixation option. We try to define the adolescence between the age of 10 years and 18 years according to the WHO, which can be as early as 8 or 9 years of age because of the differences in the bone age compared to the chronological age in certain groups. So we broadly categorize them into young adolescents between age 9 and 12 years, wherein we consider the growth remaining when planning for the management. The older adolescents between 13 and 18 years of age, because they are more like adults, we need to consider the rigidity in the fixation option rather than the growth remaining. So this adds more difficulty in decision making with a dilemma in the fixation options because they are neither too pediatric nor true adults, so to tailor the management according to the patient characteristic as well as the fracture pattern. So when we look at the fixation options, first things comes to our mind is the elastic stable intramedullary nails, specifically the titanium nails, which are more flexible, and the stainless steel rods, which are more rigid than their titanium counterparts. Secondly, the submuscular lock plate fixation. Then comes the adolescent-specific trochanteric entry interlock nails, which have gained popularity in the recent years. Finally, the excellent fixation methods, which have been in practice since ages. So when we look at the literature, there's a plethora of recommendations for these fixation options, with the advantage of one fixation method over the other. This adds more confusion to the existing thought process. So we tried to identify and group the literature recommendations specific to the particular implants. Firstly, certain groups they try to question the use of elastic nailing in older children. As to this paper from Ho and his colleagues, they found more complications in children with more than 10 years of age when they use flexible intramedullary nails. While this paper, the authors tried to analyze more than 200 pediatric femur fractures across 6 institutes in the US and France, and they tried to find out the predictors of complications and poor outcomes with tense nailing. They found 5 times more poor outcomes in children who weigh more than 49 kg and children who are overweight. In this paper from Johns Hopkins Institute, the authors found more complications in obese children when they have been treated using intramedullary rods or external fixator apparatus. This is another paper which compares the flexible nailing and the rigid lock nails for length-stable femur fractures in heavier children. The authors clearly proposed that the rigid nails were better in providing lesser complication rates and better outcomes when compared to the flexible nails. There's another group of authors who still use elastic flexible intramedullary nails for femur fractures as to this paper from Shah et al., wherein the authors use the ender stainless steel elastic nails with good outcomes even for heavier children. And this paper from Italy and France, published in Journal of International Orthopaedics in the year 2019, wherein the authors showed excellent results with elastic nailing being used for proximal femur fractures in older children and adolescents. With these two schools of thought in mind, we try to analyze this paper from the University of Children's Hospital in Colorado, where the authors tried to find whether the change in management in the pediatric femur fractures had decreased the complication rates. The authors found when they used tense nailing for stable fracture pattern in the age group between 5 to 11 years of age, showed excellent results with minimal complications. Whilst for the unstable fracture pattern in the older age group, the authors proposed more rigid forms of fixation in the form of lock plates and interlock nails for better outcomes. Then came the papers which favor the lock intramedullary nailing even for very young children, less than 12 years of age with good reports in short term. And again, this paper from Korea showed the advantages of both intramedullary nailing as well as submuscular plating in adolescent femur fractures. With all these plethora of recommendation options in adolescent femur fractures, we look at this landmark paper from Hospital for Sick Children, wherein the authors made a comparison of all four methods of fixation, including the flexible nails, the locked nails, the external fixator system, and the lock plate fixation. Except for the external fixator group, all the other three methods of fixation had excellent outcomes with a comparable complication rate. While the external fixator group, the authors showed more complications which were clinically as well as statistically significant. Finally, the authors also emphasized that if these adolescents are heavier and nearing their maturity, it's better to use a rigid implant for excellent results. With these recommendations, we could identify three criteria to be considered before planning for management. Firstly, the age of the child. If the younger the child, the less stiffer the implant we could get away with good outcomes. If the child is on the higher age is on the higher side, we might need to use more stiffer implants in the form of submuscular plates or lock nails. With regard to the fracture pattern, if it's a lens staple fracture like a transverse fracture or a short oblique fracture, less stiffer implants could be the option. While the length unstable fractures need more stability in the form of external fixator apparatus or more rigid implants per se in the form of lock plates or lock nails. Finally, the weight of the child, less than 50 kgs weight, we can get away with less stiffer implants in the form of flexible nails. But if the children or the adolescent is overweight, you might need to use a more rigid implant. Let us see some case examples. This is a 10-year-old boy with a diaphyseal femur fracture, the weight being around 35 kg. With a stable fracture pattern, he proceeded with elastic nailing with excellent postoperative outcome, as we can see in these x-rays. This is another patient, a 15-year-old boy, again a diaphyseal femur fracture, but here the weight was around 54 kg, considering the age as well as the weight of the patient. Proceeded with the adolescent-specific lock nail with excellent postoperative outcomes. Again, this is another child, a 13-year-old adolescent, but this time he was overweight with the weight of around 70 kg at presentation, so proceeded with trochanteric entry interlock nails and had no complications whatsoever in the postoperative period. The older generation interlock nails had an entry point at the piriformis fossa, which could lead on to devastating complications of avascular necrosis of the femoral head, especially in younger children and immature adolescents. So the advent of trochanteric entry nail circumvented this problem of damage to the vascularity with an trochanteric entry and has gained popularity in the recent years. Because it's a more stable construct, it can be used in unstable fractures as well as in older adolescents. But one thing just to be kept in mind is the limnar discrepancy, which can happen due to overgrowth, has been reported in literature, and caution to be kept in mind while used in young patients because of the growth remaining. Next option is the submuscular plating, which can be applied from the proximal as well as the distal aspect, as we can see in this picture. And this is a case example from Professor Mercer Rank's textbook of Children's Orthopaedics, wherein the submuscular plate has been used in a pediatric diaphyseal femur fracture. Because it is a stable construct, which can be used in unstable fracture patterns and in older children. But the complications do happen in the form of fractures and refractures, especially after the hardware removal. And recent papers have found the development of distal femur valgus deformity, which is a progressive valgus deformity, and limb length discrepancy can happen in young children being managed with lock plate fixation. So because of these complications, these need a longer follow-up. Finally, a word on the external fixators, which provide very high complication rate. Refractures do happen after hardware removal, well reported in literature, and the problem of infection also exists. So this has to be restricted for use only in open injuries in polytrauma patients or as a temporary or supplementary fixation to elastic nailing. So to sum up all the literature review and the points, these are the recommendations. Firstly, for a younger adolescent between 9 and 12 years of age with a stable fracture pattern and a weight less than 50 kilograms, the elastic stable nailing is the implant of choice. Whilst with the same age group and an unstable fracture pattern or an overweight adolescent, it's better to supplement with more rigid forms of fixation in the form of external fixator apparatus if we use an elastic nailing, or more stiffer construct in the form of submuscular plating or a lock nail. For an older adolescent, it's better to use a rigid implant, ideally an trochanteric entry interlock nail, while plating can also be an option in this age group. For external fixator apparatus, it should be restricted for usage in open fractures and polytrauma patients. This chart gives an overview of what we have learned through this presentation regards to the recommendations of the fixation options in the specific age group with respect to the diaphyseal femur fractures in children. Thank you.